Good evening and welcome to the Össur Academy webinar. Thank you for joining us tonight. We've got quite a few of you this evening. So before I introduce our speaker, Neil Jain, what I'm just going to do is take you through a few housekeeping information just to help you get the best from this. So first of all, what we're going to do is just talk you through some of the functionality that the webinar software has. So please type any questions that you have whenever you have them, and you can do this through the Q&A function. If you ever have a question that doesn't get answered straight away, we will come back to you at the end. We will try and get through as many of those as we possibly can. You can also use the chat function, which allows you to chat with the whole group or potentially just with us as well. Any of them can also be done privately, so don't worry about that. The webinar is also recorded as well, so if you want to come back to this later, it's not a problem at all. Just go to the Össur Academy section of our website and you'll find all the recordings of this and indeed other webinars in there. We will also have a follow-up questionnaire. So this is just a chance for you to give your feedback, hints, tips. We want to make this a useful resource for you. Over time, we'll build upon this and try and bring this to you more often. We also have polls. So these allow us for you to interact with the speaker, to gauge your opinion and things that go on. So just to highlight that, what we're going to do first of all is just have a quick test poll. Mike, the technical monkey, is about to switch that on. So there we go. Very simple. But what's your favorite biscuit? We do have some people joining us from various different other countries, so some of these may not necessarily mean a lot to you. But if you can select one of those as quickly as you can, and then we'll give you a period of time. And then once we've done that, so if we conclude that there, we can then look at the results. So from this, it's resoundingly the hobnob. So yeah, important scientific information there right from the start. So you can see that it allows us to actually answer the questions, and you'll see from Neil's session later, he's actually wanting you to interact and get you chatting throughout the session. We've also heard that there's a few big groups out there, so if you are in a big group with one login, do take a photo of yourself and post it with the hashtag Össur webinars, but also send us the full list of delegates that you have with you, and we're happy to send you an e-certificate as well. And there will be questions afterwards, so we'll stay around for a little bit longer, so do think about those questions that you might have as you go along. Type them in perhaps and then send them towards the end, and then we'll answer those as we go along. Okay, so what really remains for me to do is to pass you over to our speaker. Just going to tell you a little bit about Mr. Jain. He's based in Manchester. He's a sports surgeon and does a variety of arthroscopic procedures for both the shoulder and the knee. Some of his training was conducted over in Canada, and he has significant links with a lot of the sports-related groups. He's currently chairman of Boster and has lots of involvement with a variety of UK sports. So I'm going to hand over to him. So if we can just start that up now, and we'll take it from there. Thank you very much.
Great. Thanks very much, Giles. I should stress, in case the chairman of Boster's listening, I'm the treasurer, but that's okay.
Did I say chairman?
You did. And it would only get me into trouble. That's okay. So we clarified that. Apologies to everybody who's watching. This goes downhill now after the hobnob incident that we've already covered, but hopefully it will keep some people watching. Thanks for joining us on a Monday night. Probably lots of better things to do, but honestly, thanks for joining us. We'll try and make it worth your while. Share a bit of information. I'd love to learn some bits off yourselves as well. So please do use the chat function. Get involved in the interactive aspect of this, and that would be great. From a personal point of view, I want to thank Giles for the invitation and for Össur. Thanks to Mike, who's working the technical aspect. Thanks to Pete, who's going to be travelling around with a handheld camera when we get onto the examinations later. And thanks to Maxine, who's going to be doing a lot of the flicking back and forth between this camera and then the image you're about to see while we start with regards to your presentation. So if we're ready, guys, let's switch over now, and then we'll start with the presentation and we'll go from there. Great. Brilliant. So thank you again to Össur. We're going to talk about conservative management of knee injuries in sports. There's a lot of my affiliations up there. So We'll talk about non-operative treatment options with regards to knee injury in sport. I'm aware I'm a surgeon, but probably the best operation I do is the one I never have to do. And a lot of people listening tonight and watching will not be surgeons, so I think it'll probably appeal more to you than me just going on about various operations I do through an arthroscope. Then we'll move on and talk a bit about the history and examination and discuss some top tips about how we can diagnose sports injuries around the knee. And then we'll finish off by testing our knowledge, see what we've learned, and do some polls regarding some case studies. Now, knee injuries are common in sports. 41% of all sporting injuries relate to the knee, and a fifth of those are ACL tears alone. And that just shows you, first off, how common ACL tears are and why that's a big focus for us as sports knee surgeons, as sports knee practitioners. Of course, it's not alone, and there's other injuries that can happen, such as meniscal tears, injuries to tendons, cartilage lesions, and other ligament injuries around the knee as well. So there's a couple of questions we're going to come up with. With regards to an ACL in sport, well, do we always have to operate? Well, as a surgeon, I'll be the first to tell you we don't. There's no such thing as always in life, so that's certainly the case in surgery. But here's a question we want to throw open to the group tonight. Let's get going with a poll straight away. Is it possible to play at an elite level in sport in the absence of an ACL? Mike, if you could put the poll up. It's quite a simple one, this one, yes or no, no multiple choice of biscuits. And as a result, we should be able to probably come to a decision quite early. So that'll probably do for time. Let's see what the results show. Yeah, and a good split there, 70-30. And I'd probably agree with that. It is possible, but there's dependent factors. If we close that down, right, that'd be great. I wonder how many of the audience recognise this gentleman. This is Tana Umaga. He's a New Zealand All Black. He played over 60 times for New Zealand. He was a centre, and he doesn't have an ACL in one of his knees. Yet he was able to play at a really high level. As you can see, the size of his thighs are probably the size, well, I was going to say my waist, but maybe the size of both his thighs is the size of my waist these days. But he's a big, big guy, and so he's been able to cope without an ACL. But that's not the case for all people. A lot of people can't. The depending factors are the sport and the functional demand of that player within the sport. And so you can't really say it's an all or nothing phenomenon. What about the meniscus? Do we always have to operate? Is it possible to play with a meniscal tear? Let's go to the polls again. So much like last time, a simple yes or no. And as there's only two options, there's no need really to dwell on this too much. Let's see what we showed. Yeah. So again, that's interesting. It is possible to play with a meniscal tear. I think we'd all agree, though, it depends on the size of the tear. But if it's an acute injury in a young person who plays a pivot and shifting sport, for a stable, incomplete tear of less than 3 millimeters from the periphery, it probably is all right to treat non-operatively. Anything other than that, you'd be better off operating. Now, that could either be in the form of a meniscectomy or, ideally, in the form of meniscal repair, because we want to try and preserve the meniscus. Not just for the short term, but also long term. Preserving the meniscus helps prevent against arthritic change. And so actually, we're more likely to operate with a meniscal tear than perhaps we were with an ACL tear. Now, how about tendon injury? Is it possible to play with a tendon tear? What do we think about that poll? And as we got the hang of it, first reactions are the best reactions. Let's close it off there, Mike. Let's see what the team says. Oh, split decision. I like this. It's getting tighter. It's a shame we can't have a debate across the airwaves for this one. That would be good. If you close that down. But actually, it's probably the right answer. If the tendon's ruptured, yes, we do. We do have to operate, because really the muscle needs to be attached to the bone in order to function. And whether that be a quadriceps tendon rupture, as demonstrated at the top, or an Achilles tendon rupture, as demonstrated with this elite athlete at the bottom, who was unable to play on after that, operation is often the best way to consistently predict a return to an elite level. But when we talk about tendinopathy, microscopic tears, not ruptures, You don't have to have an operation, and in actual fact, it's probably better to avoid an operation in those settings, partly because there's lots of other options. Physiotherapy works well for tendinopathy. For instance, patellar tendinopathy, pre-season screening is very good as part of that physiotherapy, whether that be in a Premier League football team, a netball team, or any team. Screening of these patients makes it possible to identify people who would be susceptible to eventually undergoing patellar tendinopathy. As a result, it's possible to then offload that patient or player, or rather manage their load in a way that keeps them active, but helps their patellar tendon to regenerate. Now, we can augment that in various ways. Recently, injections have been postulated, PRPs showing some good results. Sclerosant, which was popular, is now going out of favour, but an injection around the area is possible. And then finally, bracing, and there's multiple options for bracing that can help, sometimes more than others. So let's have another poll. What about cartilage injuries? Is it possible to play with a cartilage injury? Now, this is not a meniscus tear, this is a chondral injury. It's a simple yes or no again. And it'll be interesting for me to see what the findings are with this one. Okay, Mike, let's see what we've said. 2/3, 1/3. Good split there. Okay. And in essence, we don't have to operate. Like all of these injuries, we operate a case-by-case phenomenon. And it depends on the type of injury as well. Now, if there's a cartilage piece that's come off and it's floating around the knee, that can be a loose body, and that can cause mechanical symptoms which impact the athlete from their performance. In those situations, it is best to take that piece out, or, if possible, relocate that piece and hold it and fix it in place in a bid to help. But is it possible to play with a cartilage injury? Well, many people do. That can either be a grade 1 cartilage softening or a grade 4 full thickness tear exposing bare bone underneath. And that is possible to play. A lot of players, when they've played into their late 20s and now into the mid 30s, will have had an injury to their knee, and often had an injury that results in a cartilage problem. That manifests itself and it doesn't really improve. And so they keep playing on and just manage the situation. Now, how can they manage it? Injections have been very popular. Steroids, the classic for this, but we know while it's good at helping pain in the short term, helping with swelling, it is chondrotoxic. It kills cartilage cells. So it can give you pain relief in the short term, but actually make the problem worse in the long term when the anti-inflammatory effect of it wears off. Sclerosant had popularity. And there's one study which is actually quite poor evidence, which suggested cartilage regeneration from the administration of sclerosant into a knee. It's not been reproduced anywhere else. Hyaluronic acid has been shown to improve pain in some studies, but recently the American Academy of Orthopaedic Surgeons has even highlighted, after a review of all the studies, that they cannot suggest or recommend its use for osteoarthritis of the knee. Contrary to that, though, there is growing evidence for PRP, platelet-rich plasma, or autologous conditioned plasma, as I've photographed here. And there's good evidence now suggesting that that helps with pain and symptoms when someone's got a cartilage injury within the knee. Stem cells, though, could well be the future. The evidence isn't quite there yet, but the hope is that as time goes on, as technology improves, science improves, we can hopefully show some good evidence for stem cells, even though it's not there quite just yet. Another option would be bracing. Now, how would this work? This is an example of where a brace might help. If someone's got a subchondral bone bruising on a femoral condyle, there's no real surgery that can help recover that patient quickly. It just takes time. That patient improves with rest and rehabilitation. Now, through that time of rest, particularly in the elite athletes, we want to avoid muscle deconditioning. We want to avoid atrophy. So in the ideal situation, we would want to keep that player moving and using the musculature. And a way of doing that is an offloading brace. So for instance, in this picture, we're trying to demonstrate the medial side of the left knee in this individual being an area of cartilage wear. By using a brace like this, the functionality of it forces the leg into slight valgus, offloading the medial compartment. And that would allow an individual to keep playing, or at least training, keeping their muscles active, and thereby decreasing the rate of atrophy. So bracing for a cartilage injury probably could be indicated to offload a compartment. And actually now we can use that kind of thought process in conjunction and combination with anti-gravity loading. We're probably all familiar with the Altered G treadmill, where we can dial in a degree of weight bearing and loading within the treadmill, so a patient can keep running but not put a full force through their joint. That should help not just decreasing the atrophy that we talked about, but also stiffness within the knee, and thereby offer potentially a quicker return to play for that player, although that's not yet proven. So the final point, or the final type of injury or group of injury we want to discuss, is ligament injuries in sport that aren't ACL. Is it possible to play at an elite level with a ligament injury in sport? So let's go to another poll. This is the last poll for a short while. It's a simple yes or no. And like most things, if we go with our first instinctive answer, that's often the one we want. So let's draw the poll to a close now, and let's see what the results. And I think, yeah, that's a good answer, team. Very good indeed. The vast majority of us would agree that it is possible to play with a non-ACL ligament injury. And in fact, PCL injuries and MCL injuries do better most of the time without an operation. But again, it depends on the functional demand of the sport, the position of the player, and the size of any augmenting brace that a player might need. For instance, an MCL, it's extra-articular. The medial collateral ligament is outside the joint, and it heals itself. Where bracing helps is that it controls the valgus deformity or valgus strain on the knee during the process of healing, thereby allowing the MCL to heal. For instance, here, we've got a picture of a normal knee and a picture of potentially a torn medial collateral ligament here. Any valgus force on this would keep distracting the two ends of the ligament apart from one another, thereby potentially stopping them healing and forming bridges between the two. Or bridges may form, but the ligament may be elongated relative to what it would normally want to, or normally should be. That could leave some residual laxity within the knee in terms of valgus force. There's a variety of hinged type braces that exist, but they effectively help that varus valgus type position and maneuver, and thereby allow the MCL to heal. It's a similar story for PCL. The majority of PCL injuries, posterior cruciate ligament injuries, are treated non-operatively. All grade 1 and grade 2 injuries should really be treated non-operatively first. And that involves a significant investment in quadriceps rehab with appropriate bracing. And that's been shown to give good outcomes in sport, and certainly a decreased risk when compared with the surgical options. Here again, we've got that diagram as well. This time we're trying to look, if we follow the cursor, behind the ACL at the PCL, and there it is torn, just demonstrating a torn PCL. But what's the function of the PCL? Well, we'll touch on this a bit later with the examination findings. The PCL prevents posterior translation of the tibia on the femur, and so we test it with a posterior draw. So really we want a brace to counteract that, to push the tibia forward on the femur. These are the traditional braces, and as you can appreciate, they're all quite big and cumbersome. They were difficult for someone to be active sportingly with them, particularly the one furthest on the left. They were also static braces, so they adopted the same amount of anterior force on the tibia through a range of movement. But when we actually look at the PCL itself, as we follow this graph, we can see there's more force withstood by the PCL in deeper degrees of flexion. So actually, we'd want something that adjusts through a range of flexion. We now have it. There's now dynamic PCL braces, which we can see increase force through a range of flexion, as opposed to these previous static braces demonstrated with the yellow line on the graph here. And the way it does this is with this contraption at the back of the calf. This tension wire works in such a way that when we flex the knee, there's more anterior force placed on the tibia, therefore mimicking the native PCL better. And that dial means we can dial in a degree of tension and increase it as required. And what we can see in this graph is that the dynamic functional brace for a PCL matches more the normal PCL movement or forces through a PCL, as opposed to the static one, which is the flat line along the bottom of the 3 lines. So to bring to an end that first part, just to summarize, we've got lots of options for every knee injury, and some options are better than others. The right option, though, that depends upon the type and the severity of each injury and the individual and their functional demands. Surgery is sometimes indicated acutely, and sometimes it's absolutely the right thing to do. It may also be the right thing to do following a period of non-operative treatment, often failed non-operative treatment. That being said, though, conservative treatment, non-operative treatment, is much better for a large number of knee injuries around the knee. And while we've touched on a few of the options tonight, as future advances continue, we'll hopefully have more tools to our belt going forward to help treat these. So what we're going to do now is switch to history and examination, unless there's any pressing questions from the question booth, Max. Okay, brilliant. So what we're going to do is go through some cases first. We're going to talk through some top tips of history and some examination. Max, if you could go back to the slides. And we'll talk through a few little tips about certain things to look out for in the history, some things to look out for in the examination as well. We're all familiar with taking a presenting complaint from our patients. But what I try and encourage people to do next time you take a presenting complaint of a knee problem, specifically ask the patient, ask the player, what's your presenting complaint? You're only allowed to pick one of these. Is it pain? Is it instability? Is it weakness? Or is it stiffness? And the reason why I'd suggest that would be a good thing to do is because they give you a real clue about what the problem might be. If the problem's pain, it's more likely to be a cartilaginous or arthritic problem in the knee, or a meniscal problem. If it's instability, you can hone your eyes down and it's more a ligament type injury. If it's weakness, that could represent a problem with the tendon or the musculotendinous connection to allow movement. And if it's stiffness, that's either due to swelling or due to arthritic change. And it's amazing once you start asking these specific things and really stressing to the patient, you can only pick one of these. You can help really narrow down what the potential diagnosis is. Now, obviously, some of the time it might be a combination of of 2 or 3 of these, and that's allowed as well. But it's always good to just ask, you're only allowed to pick one. The other big clue, and we'll follow on with this in the cases, is the mechanism of injury. Ask the patient what you were doing. With sports trauma, there's often an injury. And we know that certain maneuvers, particularly around the knee, give a big clue as to what the injury might be. So asking in as much detail as possible what the mechanism of injury might be is really important. Did you hear a snap, a crack, or a pop? Well, that can give you a clue as well. That's a real classic sign of an ACL. I've torn my ACL in my right knee many years ago now. I heard a crack. I looked around and I was convinced that everyone had heard it, but apparently I was the only one who heard it. And that's not unusual either. Ask the question, were the patient able to play on? If they weren't able to play on, that's a significant injury. So we're talking a big injury there. And similarly, how quickly did it swell up? Well, the ACL is an intra-articular structure with a blood supply. If that tears, the knee is going to balloon up very quickly within hours because there's bleeding into the joint, a hemarthrosis. A meniscus classically doesn't manifest itself until the next day. So that's useful to know as well. And these are the kind of things that can really give you a clue as to what the diagnosis is. Okay, so a few tips later. So talking about a mechanism of injury, looking at this, you can see the patient's right leg, his foot in particular, has been stuck. It's held in one particular position. His thigh is rotated inwards, resulting in an external rotation of the tibia on the femur. And this is classic for an ACL type injury. As we can see here in this diagram, A is a normal knee. B shows an ACL tear about to happen with an increased valgus strain. So in this instance, you get a valgus injury to the knee, the MCL gives first, and as the knee goes into further valgus, you tear the ACL as well. That's often associated with a lateral meniscal tear, because as you see, the lateral femoral condyle gets pushed down into the lateral meniscus. Another type of injury is where the femur externally rotates on a planted tibia. And that rotational force can cause a significant injury to the ACL. The last type is there, internal rotation of the femur on the tibia, or external rotation of the tibia on the femur, relatively speaking. And as that subluxes, the clunking back of the femur on the tibia is akin to the pivot shift test, which we'll go on to talk about a bit later. Again, you can tear the MCL and the meniscus as well at the same time. The final thing that's not shown on there is this hyperextension varus type injury, where you tear your ACL as well as your posterolateral corner. Here's a very standard cartoon. This one's out there for our friends across the pond over in the USA and Canada. Anyone listening or tuning in from there, thanks very much. This is for you. This is in American football, so you can see the right leg of this player is planted as the opponent's gone into him, and it's forced the knee into valgus. And this is classic of a medial collateral ligament injury. The medial collateral ligament will be stretched and eventually get to the fatigue point there. This is going the other way. This is in football, where a player has stretched out their right leg, and the impact of the opposition player has forced the knee into a hyperextension varus type injury. This is a bad injury. It can be associated with lateral collateral ligament injury, posterolateral corner injury as well. So this is more than just your standard knee ligament injury here that we can see. Now, I see there's 99 participants on the webinar. There's 4 people with me here in this room. In orthopaedics, we like a mantra, and we're probably all familiar with our mantra of look, feel, move, special tests. So wherever we are in the world, whether we're in England, Scotland, Ireland, Wales, if we're in Europe, if we're in Össur in Iceland, if we're in Canada or America, say it with me now. Look, feel, move, special tests. Look, feel, move, special tests. Well, thanks to the 4 of you here who didn't say anything, but I could hear everyone else saying it, so thank you very much. That's what we do. That's what we've learned across the years in orthopaedics about how do we examine a joint, okay? What we're going to do tonight is, though, we're going to offer some hints and tips, looking at specific diagnoses and what the problems might be, or what tests we can do to help. So we're going to start with a meniscus tear. Now, I'd like to welcome back Giles. If we cut to the big screen. Giles has undergone quite the transition here. You can't quite see it at the moment. If we come forward, he's wearing a lovely pair of shorts. So he's going to be our guinea pig for the night. So thanks very much to Giles. Have you pop yourself on the couch? So a couple of things we talked about there. We like to look for an effusion, a swelling within the knee joint, okay? Now, there's a couple of ways of doing this. If you come closer, Pete, that'd be good. So Pete's got the handheld, so he's going to come closer and have a look at this. We see 2 gutters, the medial gutter here and the lateral gutter here, and you can see they're quite shallow. Now, if Giles had an effusion in his knee, I'd be able to milk it down and fill this, and then empty it, and then try and push it back here. Very subtle, but what you would see is that this cavity here, if you like, would become quite full, okay? The other way of testing for an effusion, again, milking down the suprapatellar pouch, getting all the fluid in the knee. And we can all do this at home tonight. If we all run ourselves a bath and we get our rubber duck out and we just start tapping it up and down, we can ballot our rubber duck on our bath. And that's what we would do here. We try and ballot the patella on the bath water of the effusion within the knee for Giles. Now, the other thing we looked at while we're in this position is joint line tenderness. So, top tip here, we always used to do this when we were sitting on the foot doing the draw test as well. And when we were at medical school learning this, we put both our fingers there and do this. Okay, we can't work out which side's problematic there. So Pete, if you come around here, maybe have a look from over my left shoulder. What you want to do is try and feel in the joint. You can run your thumbs up and they'll just drop nicely into the joint. And then really feel around the medial joint line. And I'm looking at Giles in his eyes to make sure I'm not hurting him, because that'll give a good clue as to whether there's a pain. And if there's joint line tenderness, that's a good example or a good indication of there being a meniscal tear. Okay, just stand up for me now, Giles. Max, if you flick back to the slide. So they're the top two. We're going to do a couple of different tests now. The squat test and the Thessley test. And these may be new tests for some people, they may be old hat for others. Then we'll go on to the final two. So I'm just going to stand in front of Giles here. Pete, if you come in front of me, and we'll come back to Pete's handheld camera now. So what I like to do when we're testing here is just look at the patient's knees and their legs. And what you want you to do, keep your feet pointed forward and just squat down as low as you can, okay? And come back up. Now, often if someone's got a meniscal tear, that'll be painful for them and they'll point specifically to an area, normally medially or laterally. If that doesn't highlight something though, what you can ask a patient to do is just externally rotate your feet, stand like a duck and squat down again that way. And by doing that, you're translating more force across one of the paired tibiofemoral joints. And then finally, turn your feet back in and go in that way. And sometimes you might be able to pick up the odd clinically symptomatic meniscal tear like that. Just come and stand there now, Giles, stand opposite me. What I'm going to ask you to do is just put your hands on mine just for balance. The other test we were describing, or we're about to describe, is the Thessley test. So named after a place in Greece, Thessalonica. And this is a really good test. If I ask you to stand on your right leg, I want you to swing your left leg in front and behind like that. And effectively, that's great. Okay, you good? What Giles is doing there is he's taking his femur and he's grinding the meniscus between the femur and the tibia, trying to elicit pain. And if he has pain with that, that's a positive Thessley test. Now, it's important to realize, because the nature of the knee joint and the way it is, just doing that in extension is not going to give you all the answers. So we're going to do it again. This time I want you to bend your knee slightly and really give it a good twist. And you will pick up on some meniscal tears in flexion that you've not been able to pick up in extension. That's great. Okay. Let's put back up on the couch now. If you just roll onto your front to start with. And that's effectively a bit of a similarity to the next test on that list, which was the Apley grind test. Apley, obviously one of the godfathers of orthopaedic surgery in England. He described this test of grinding, and that's what we're trying to do here. He described it at 90 degrees, but what you can do is, as you come into extension, keep doing it. And what I'm trying to do is what we were doing standing up. The disadvantage of this is I can't see Giles's face. I don't know if I'm hurting him or not. So that's not a great test. And then if you roll back onto your back, finally is the one we're probably all aware of, which is McMurray's test, which, depending on how you do it, some people would do it with a bit of a wiggle this way, with a bit of a wiggle this way as you come into extension. Some people just will hold the leg like this and wiggle it as we go up and down. There's lots of variations of it, but it's been seen in the studies to be suggestive it's not very sensitive nor specific. And so many of us don't actually use it in working life and practice. The combination, though, is always better than one off on its own. So if you've got someone with joint line tenderness and effusion and a positive Thessley test and a positive squat test, that'll give you good information as to whether or not there's a meniscal tear. Okie dokie. Let's go back to the slides, Max. Thanks. So next up is an ACL. So we're probably, most of us listening to this will be quite familiar with how to test for an ACL. We test for an effusion the same way, but then we can also test with an anterior draw and a Lachman's test. So let's come back to me, Pete. Anterior draw test, we'll probably all remember from learning this. We sit on a patient's foot, we stabilize the foot, we stabilize the ankle, the tibia, fingers up into the hamstrings to relax the hamstrings, and we gently rock the tibia anteriorly on the femur, and we can see that quite nicely there. Okay. Now, what should happen is that the ACL should be intact, thereby preventing excessive anterior translation on the femur. But what's interesting about that test is that's a test of convenience. We can do it in a nice calculated position. The ACL itself isn't greatly functionable at 90 degrees. And so really it's a bit of a wasted test. What's more important is the Lachman's test. A good way of doing this is asking a patient to just drop their leg over the edge. If you rest your head back, Giles, go all floppy and relaxed if you can. And at about 30 degrees, we can see there's a lot more translation. And that's actually more relevant because 30 degrees is the point at which the ACL is going to be at its highest tension. Now, if you're like me and you've got small hands, there are tips we can counteract that, particularly with big rugby players. And this is a good way. You would have seen people before rest someone's leg on your thigh, stabilize the femur, and you see there, it's a little bit easier to do. But in life, we're blessed with more than one sense. We don't just have to look, we can feel as well. So a top tip that I'd encourage everyone to do is when you're stabilizing the femur with your hand, try to place your finger into the joint line, and then it gives you the sensory modality of feeling with your finger as well, the degree of displacement, as well as being able to see. That's something worthwhile doing. Okay, you all right there? Mm-hmm. All right. Now, in case anyone's watching in Italy, I'd like to put a shout out to Professor Lelli in Bologna, who's recently tried to popularize a test as well. And this is an interesting test. If you just rest your leg down on mine, what we're doing is we're just going to push up on Giles' thigh. So effectively, we're causing anterior translation of the tibia on the femur. But because the ACL is intact, his heel lifts off the bed. His tibia doesn't translate excessively. Now, if we do it on this leg, can we see the difference? We only found this out in rehearsals. So Giles has actually got a torn ACL in his right knee, so that shows a positive finding. But the function of the ACL isn't just anterior, posterior draw. It doesn't work just in 2 dimensions, it works in rotation as well. And so really the most clinically relevant test, I think, is the pivot shift test. And a way to do that, internally rotation of the leg, valgus force applied, and as we flex up, we would take a subluxed tibia and it would clunk back into the correct position when it gets to about 30 degrees. Few parameters we need. We need the intact MCL to do this, and we need a functioning iliotibial band, because what happens is the rotation there and the valgus force subluxes the anterolateral aspect of the tibia anteriorly, and as we get up into 30 degrees, that's when the ITB fires, and that's what pulls it back, and it comes with a very powerful clunk. Now that only happens with an intact MCL because the pivot of the knee, which would normally be the ACL, in the absence of an ACL, the pivot shifts, and it shifts to the medial collateral ligament. And that's why you get this clunk. And it's very similar to that maneuver that people will describe where they've planted, twisted, and the leg gives. If you're effectively reproducing that. On the small chance that Dean Garrett, the former Charlton Athletic physiotherapist, is watching this, I remember when you did that to me, and it really, really hurts. So actually, rather than forcing it through and having that clunk, it's better to just look at the patient's face. Much like we do when we look at shoulder instability and we bring someone up into the apprehension position, and you can see it on their face, they're really worried about that position. It's similar phenomenon with this in the pivot shift test in the knee. So I certainly don't like to force that. Okay, Max, let's see what's next on the slide. So that was the ACL. As you can see, there's lots more tests on the PCL though. So let's go through them now. All right. Again, there's an effusion. We can look for that. And when we're up in this 90-degree position, we can look for a posterior sag sign. Now, we talked about the tension of a PCL. A PCL is more taut when it's in flexion. So actually, the 90-degree position works for the PCL, whereas it wasn't quite so good for an ACL. And the posterior sag, if you come back in closer, Pete, just come and look at this bit. So when we lay a pen on the front of the knee, we can see that there should be a gap between the pen and the patella. Okay, there should be clear air underneath there. Now, to mimic this, what it would appear with a posterior sag is that the pen would be flush instead. Okay, so that's your first clue about what could be going on. Then it would be a posterior draw sign. And that's where, much like we had in the anterior draw test, but this time we push backwards, like so. Now, beware the false positive anterior draw sign. And the way to tell that is to run your thumbs over the femoral condyles onto the tibia, because it might actually be that the patient's leg is in a posterior sag position, and what you think is a positive anterior draw test is simply bringing them back to normal from a posterior sag. So it's good to get that bit going. All right, let's bring your leg to there. The next test is what we call a quads active test, and it won't be possible to demonstrate here, but it's quite a dynamic test when we see it. What you ask the patient to do is to tense your quads in this position, and what happens is the patient goes from a posterior sag to bringing the tibia forward, and it's quite a visual effect. Just relax a second, Giles. What you can do effectively is take the pen as it sits there, ask the patient to tense the quads, and it'll almost lift the pen off the patella as well with a positive quads active test. Okay, let's just go back to the slide quickly. So we've done the quads active, we'll cover recurvatum and hyperextension, and then we'll do the reverse pivot shift as well. So let's just go back to Pete now. You rest your leg down, Giles. That's great. So what we'll know is that a lot of people have a degree of hyperextension in their leg, okay? When you've got a PCL injury though, often just lifting the patient's toe can lift the foot quite high up off the bed. And that's a phenomenon we call recurvatum of the knee, or real significant hyperextension. We're talking beyond 15 degrees, or 10 degrees or so beyond what their other knee would be. And then finally, there's the reverse pivot shift. This doesn't always work, but effectively it's the same phenomenon. Internal rotation, this time in flexion though, bit of valgus, and with a bit of anterior force of the tibia on the femur. And as we come into extension this time, the tibia may clump backwards. That would be a reverse pivot shift. Okay, so that's PCL covered. Some tips and tricks there for testing a PCL. Let's move on. Our next one's fairly straightforward actually. We're probably all familiar with how to test for the collateral ligaments. There we go. All right. So the medial and lateral collateral ligaments, here we can see why you'd have an excessive problem with a torn medial collateral ligament. A direction of force laterally opens up that medial part with or without an ACL tear as well. And so recreating that force would show an opening of the medial collateral side. So let's come back to Pete for a second and we'll show how we test for them. So again, using Giles' left leg, medial collateral ligament, that's the force I'm applying on the lateral aspect. We're pushing in and we're trying to open up his medial side. It's not budging at all there whatsoever. Now, if we come up into slight flexion, we'll see it does open up a little bit, and that's just normal. That's normal phenomenon there. All right. To test the lateral side, well, it's quite simple. We just reverse. So Pete, you come the other side of me, mate. This time we're going to push medially and open it up into varus, and there's no opening whatsoever. Maybe, and then a little bit in flexion as we relax those lateral structures. Good. All right. That's great. Let's go back to Max. Let's have the pictures back up. Because the last thing we're going to test for now is the posterolateral corner. As you can see there, big injury. If you tear your posterolateral corner, your knee's in a position where it shouldn't really be. Again, there's hyperextension and recurvatum, probably best demonstrated in this picture than it is more in Giles and his knee. But then there's also other tests we can do, traditionally the dial test, but there's other tests we can do as well. So to demonstrate that, let's go back to Pete. Giles, can you roll onto your tummy? So the dial test traditionally is more looking at the patient's feet. So the best way of looking at this, Pete's going to look over my shoulder I'm going to ask Giles to keep his knees together, keep them pointing down through the bed. I'm just going to bring him up to 30 degrees, and we apply an external rotation phenomenon on his feet. And this should be the same. Now, for instance, if one only went to here on his left, but his right went out to here, that would be an abnormal dial test. We'd see excessive external rotation on his right leg compared to his left. And that would be consistent with the posterolateral corner injury. If we go up to 90 degrees, that test was at 30 degrees. And if it was the same phenomenon at 90 degrees, that would suggest an associated PCL injury as well, a posterior cruciate ligament injury, as well as a posterolateral corner. If it's normal, that would suggest that the PCL is intact. All right, just roll onto your back now. As I say, that's more of a traditional way of assessing it. It's not always that accurate, and partly is because we're isolating the posterolateral corner only. What's quite a good thing to get familiar with and get into the habit of is trying to do a rotational Lachman's test. So what we're trying to do is rotate the anterolateral tibia here, pivoting around the medial side. And then what we want to do here is externally rotate the leg again and see not only if there's rotational deformity or rotational abnormality, but where that abnormality is. For instance, is it an anteromedial problem? If so, the anteromedial tibia will come forward. Or is it a posterolateral rotational abnormality? The anteromedial tibia would stay where it was supposed to be, and the posterolateral tibia would go posteriorly. And that's important because that will tell us effectively which bit we need to focus our surgery on if we're going to go down the surgical route for rotational stability. Because if the problem's anteromedially, doing a posterolateral reconstruction won't actually change the problem. So that's why it's useful to get these clues when it comes to planning our surgery as well. Okay, Max, let's go back to the slides for a second. Great, so we covered most of them there. The last thing to say was, yeah, we like to do a varus stress as well at the same time, because we want to know whether or not there's been multi-ligament injury, and often with a posterolateral corner injury, we've already talked about a PCL injury as well, but often that comes with a lateral collateral ligament injury. Okie dokie, so before we go on to cases, I think we've got a question, have we, Max?
Yes. Are post-lateral corners sometimes overlooked, as some studies have suggested, if left untreated, could cause residual instability?
So to answer that question, do I have a poll? Is it just yes or no, or can I elaborate on that, Pete? Can I say more than yes or no?
You can elaborate.
Thanks, mate. Thanks. Yeah, I think they are underlooked or overlooked. I think you know, it's very interesting, isn't it? I think one of the. Oh, could you repeat the question? Ah, I see. So you couldn't hear Max asking the question, right? I'll repeat the question then. So, where was it? Oh, there we go. Yeah, so the question from Jay Patel, thanks Jay for tuning in. Are posterolateral corner injuries sometimes overlooked, as some studies have suggested that if left untreated, they could cause residual instability? I'd have to agree with you, Jay. I think they are overlooked sometimes. I think, like a lot of things in life, you know, unless you're looking for something, you're not going to see it. And I think that's why the more we have a look and the more we try and test for it, and we have a high index of suspicion, the more we should look for it. Because if you've got a posterolateral corner injury and an ACL injury, and you just treat the ACL injury, particularly surgically, you're still going to have a residual instability. And that would ultimately put excess abnormal forces on your ACL reconstruction, and it's more likely to fail as a result that way. So, yeah, I'd have to agree with you. Great. So, let's test what we've talked about then, I suppose. We've got some more polls, but this time it's a bit more fun than biscuits or yes and no answers. We're going to run through some cases, okay? So let's go to the first case. This is a 22-year-old basketball player. She's gone up for a rebound. She's landed and her knee has buckled underneath her. She's had swelling immediately. She's been unable to play on. And then after that, she's complaining of instability. She tries to put weight on her leg. She just doesn't feel comfortable with it. When we examined her, she had a positive anterior draw test, a positive Lachman's test, and a positive pivot shift test. And as you can hopefully see with these still photographed pictures, you can really see the knee collapse into that valgus type position. So let's throw this open to the poll. What do we think is happening? These are our choices. And you can have more than one choice if you like as well. ACL injury, PCL injury, posterolateral corner injury, medial collateral ligament injury, lateral collateral ligament injury, or a meniscus injury. What do we think is going on? I'll give you a little bit more time for this because there's probably more thought in it than yes or no, isn't there? But we've all got homes to go to, so we can't give you all the time in the world. So Mike, shall we draw it to a close there? Let's see what we said. Boom, look at that. Very good, very good. Yeah, absolutely. So this multiple choice aspect has clearly worked really well here. So kudos to you, Pete. Well done for putting that in the polls. I think absolutely right. The clues were there for an ACL tear. I think there's enough there to suspect potentially an MCL tear. And often with that combination, you'll see a meniscus tear as well. And so probably that index of suspicion goes in that order that we've demonstrated with the polls. So well done everybody. Good work, team. Those who said a posterolateral corner injury, you're not necessarily wrong because you should have an index of suspicion for it and you should look for it. So that was the right thing to say as well. But this is classic of an ACL injury. Now, look at this one. This is a bit more severe, isn't it? Look, crumbs. I don't think his leg's meant to bend in that direction. Anyway, this one's again for our friends across the water. This is an American football player. They were running, they planted their foot on this artificial turf. Their foot got stuck and their body continued to kind of travel over the top of it. And they felt their knee buckle. He kind of went into a hyperextension position, as we can see here, but also a varus type position as well. And he had significant swelling immediately. He certainly couldn't play on. And his knee was wobbly as heck. It was very unstable. As you can see here, he definitely would have had positive recurvatum. His dial test was positive, and his rotational Lachman's test was positive as well. So what would they be clues for us? What injuries would we consider for this individual? Let's go to the polls one more time. And again, we can choose more than just one for this, but there's probably one that's going to dominate the outcome again. That being said, it can be a complex injury, and that often means more than one diagnosis. So let's give you a little bit of time to put anything in you wish. And then we'll bring it to a close shortly, Mike. That'd be great. Yeah, good. Really interesting findings here. So this is a classic position of what we call a multi-ligament knee injury. Normally, it's the posterolateral corner that goes. That can often be associated with a PCL injury as well. So it's good that those two are quite high up on this. The other clue here that I didn't write down in the case, but I think we mentioned, was that it was hyperextension and varus. So when that happens, it's not just posterior, it's also lateral. So it's often PCL, posterolateral corner, and lateral collateral ligament that all goes together. That can also have the ACL go at the same time. But good that we've all thought about the various options. So this was to try and demonstrate and highlight for people the importance of the posterolateral corner. This individual pictured actually had a catastrophic injury. It was a multi-ligament knee injury, and he actually had peroneal nerve injury as well. Amazingly, he managed to get back to play, and he now plays for the Dallas Cowboys in the NFL. A real great story about how he came back from what was a career-threatening injury. Okay, so final case now. Let's bring it back over this side of the Atlantic to a 20-year-old soccer player, or what we would call football. This player's twisted and he's had pain when he played. He wasn't able to play on, but he didn't really swell up until the next day. Now he comes into the clinic about 4 weeks later complaining of some locking intermittently within his knee. He was tender to the joint line when we palpated it, And he had a positive Thessaly test and pain on squatting as well. So let's see what the polls say for this one. Come on, everybody. If you're not taking part in a poll yet, be bold, be brave. One last time, this is your last opportunity to take part in a poll tonight. Goodness knows how long you'll have to wait for the next Össur webinar. Get it out of your system right here, right now. Okay, that's enough filling from me. Mike, let's see some answers. Boom. Who needs an MRI scan with a history like that, right? I think everybody's right. It's good. You can't discount the other ligamentous injuries, but actually, given the evidence or given the history, we were trying to describe a meniscus injury. And that indeed, Mike, if you close that, that indeed is what we were trying to demonstrate as well. So just to recap, we've gone through a bit of a whistle-stop tour over the last hour based on first a lecture talking about knee injuries in sport, and particularly the non-operative treatment options that we are. Hopefully it's given everyone a flavour to think about what options exist. We've talked about history and examinations, some top tips perhaps to get ourselves thinking in a slightly different way. And then finally, we've gone through some case studies. And I must commend the audience on the answers. Hopefully that means that you enjoyed the talk and that things were going well and the message has been relayed. All that's left for me to do is to certainly thank Össur, thank my colleagues here, Peter, Giles, Mike and Maxine. And we're going to throw the questions open now, see if there's any questions coming. So thanks, biggest thanks of course to yourselves. Thanks for tuning in and listening, and welcome.
So to give you a chance to write some of your questions, I'm going to ask a couple of questions and also repeat a couple of ones that are in the chat. So there's a question from Niels, and it's with regards to traction of the knee. What are the results from that? What are your thoughts on that?
It depends. It's difficult in this forum really to bounce that back at Niels and ask what does he mean by traction?
It was actually when you were going through the individual treatment options, that one popped up. So we'll perhaps come back to that one. And what is your consideration to operate on an ACL until what age?
So for me, age doesn't matter. As I get older, I'm suddenly feeling there's no such thing as old age. What maybe I once said was older, suddenly appears to be young, fit and healthy now. Effectively, you're treating an individual. And I can give you anecdotal patients I've seen over the years. I've seen an 81-year-old man, once upon a time, who had an injury which we would not have done a keyhole surgery for traditionally. If we look at the evidence as a whole, we would have said he's got an arthritic knee, we have to do a knee replacement for him. The guy happened to be the world record holder at the 400 meters for over 75s, and he was 3 months away from taking part in a world championship for which he was the favourite. You give him a knee replacement, he's not going to do well. So against all the evidence, we scoped him, we debrided his meniscus, cleaned out his knee, which we shouldn't do now, according to all the studies, and he did very well. He went and won a gold medal at the World Championships. So age in itself is not a criterion for me. It's about the symptoms of the individual. So it's a good question. We have to consider all these options, but I wouldn't rule anyone out or in based purely on age for an ACL reconstruction. Partly because as well, someone can be 50, 55, 60, 70 even. If they've got a normal looking knee and their problem's instability, then you can help them gain stability in the absence of a knee replacement, which would be great, right?
Okay, great. And just wanted to ask, with the amount of sports that you're involved in, what's the one that you have your passion with? What's the one that most excites you from a patient point of view?
Well, the big thing for me is American football, actually. I know we've got potentially one or two people from over the pond in North America here. I was tipped off that there may even be someone from the University of British Columbia listening. If you are, great to see you again. Relatively speaking, I can't see you, you can see me. But I had a great time in Vancouver with the University of British Columbia Thunderbirds, Canadian football team. Loved looking after them. You know, it's a sport I used to play myself, and I love talking to guys from North America because I played collegiate football, which I guess the University of Southampton Stags doesn't quite meet up with the Alabama Crimson Tide. But it was good for me, right? And it's actually quite a fascinating sport anyway because of all the different positions that exist. and the different functional demands. And it's a great example of how, as a surgeon or a health practitioner within sport, understanding some of the nuances of a sport in itself helps you to come up with some clinical advice and clinical decisions. For instance, a defensive back, now for those who don't follow the sport, the quarterback will get the ball, they'll throw it to a wide receiver, and the guy marking the wide receiver is the defensive back. They spend a lot of time running backwards in the game. So for those people, if they tore their ACL, for instance, the graft choice is important. If we take the hamstrings as a donor for the graft for those players, that would impact their ability to run backwards at speed. And so these things are useful to know in terms of what we can do to help the players.
Okay, fantastic. So we've got a variety of questions. There's actually 8 open questions, there's a few in the chat. So starting from the top, Mohammed asked, does medial knee compartment instability lead to early degeneration in the knee or lateral patellar tract?
Yeah, I think when you've got a degree of instability within the knee, you're creating abnormal biomechanical forces across the knee joint. And what we know about the majority of structures within the human body is that they can cope with compression, they can cope a bit with tension. And in particular, articular cartilage, it can't cope with shear very well. And so the instability that you have in a knee joint sometimes creates shear forces across the cartilage. That ultimately will shear off cartilage, and that would lead to degeneration. So I'd agree with that statement, yeah. And
Ali asked if there's point tenderness on medial or lateral femoral condyle, which aggravates by weight bearing.
I think that's a great point, Ali, and maybe we should go into that in a bit more detail. Pete, have you got your handheld again? Is that possible? And we can show a couple of subtleties with examination. So I think what Ali's getting at is when we do the joint line tenderness exam, as we were demonstrating on you earlier, Giles, if we palpate in the joint line here, if that's painful for somebody, that's representative of meniscus. But actually, another subtle thing is to differentiate between, if you come in closer as well if you can, differentiate between the joint line and the femoral condyle. So Giles may say he's tender there, but not tender there. Well, that tells me he's tender over the femoral condyle and not over the meniscus. So that's a good thing to do, to differentiate between the two, because that helps predict. If we did a meniscectomy for Giles, it may not actually take away his pain, because his pain's probably more from his femoral condyle. So Ali's absolutely right with his point there, and that's something worthwhile looking into in our exam as well.
Okay. Is there an optimum time frame for operating on a meniscal tear?
Yeah, certainly if it's a repairable tear, the sooner you do it, the better, really. What we know is that there's different types of meniscus tear, and some are more likely to heal than others. What we know as well is that the longer that you leave it from that time to the repair, the less likely is a repair to heal. And as a result, therefore, we would want to try and get that patient in. If they've got a viable meniscus and one that we could repair, then we want to do it as soon as possible. And part of the reason for that, Giles, is that if the meniscus is unstable and it's effectively flipping in and out of the joint, it's getting ground down by that repetitive cycling of the femur on the tibia with knee bending. Eventually, that'll crush the tissue quality of the meniscus. So if we leave it too long, we try and repair it, the sutures will just cut through the meniscus.
And on a similar point, Aaron's asking, from a surgical point of view with meniscal injuries, is it mechanical symptoms of locking that sort of informs you or suggests that your sort of possibility of operating? Is that something that you consider? So
if someone's got locking with the meniscus, that suggests an unstable meniscus tear. And effectively, the meniscus will be coming into the knee, blocking the range of movement. And that's what the locking is. And then they'll wiggle the knee around to loosen it up, and eventually the meniscus will flick back to its seated position, and the range of movement will recover. Locking's a big symptom.
Okay.
But actually, in the ideal panacea healthcare world, if someone had a knee injury on day 1, they'd be MRI scanned on day 2 if they've got a hemarthrosis. And that way we'd be able to tell what the problem was. Is it an ACL injury? Is it a meniscal injury? And then what we can now see, particularly with 3T MR scanners, the great detail involved with those now, we can see more likely that tears that are more likely to benefit from a repair than tears that aren't.
Okay, fantastic. There's quite a few questions coming in.
Great, keep it coming, yeah.
So Adnan asked, how early do you want to repair an ACL?
Well, that's an interesting question. And I think it depends if he means repair the ACL. There's a recent vogue now for actually repairing a torn ACL. So you take the ACL stump or remnant after the tear and you effectively reattach it to the femur. Now that's only really possible if it's torn off the femur. If it's a mid-substance tear, it's much harder to do. There's still some advocates who would recommend doing that. If the question is how soon would you want to reconstruct the ACL, which is still, generally speaking, the more established surgical option, it depends. Because if most of the time people fall into one of three categories. There's those like Tana Umaga who can do things I can only wish to do, play for the All Blacks. I mean, that takes one heck of a load on your legs. And he's done that without an ACL. On the complete opposite scale, you've got people who can't even walk down the street and their knee gives way. Most people are in the middle, though. They can do day-to-day stuff, but when they come to do pivoting and shifting sports, their knee can give way. And so really, it's about having that discussion with your patient about what their hopes are, what their expectations are. Mm-hmm. Speaking from my personal experience, when I was 18, when I tore my ACL, I wanted to get back playing sport. I had it done when I was 19, and I was back playing sport when I was 20. You know, it worked out for me. It worked well. I'm not going to reveal how old I am now, but I'm a bit older. 20 years later, oh, God. And if anyone's good at maths, you've worked it out. 20 years later, here I am. My life circumstances are different. So even though I've got a defunctioned ACL in my right knee, I'm not rushing to have it reconstructed because I can modify my activities because I know what the rehab's like. I know what the surgery's like the second time around as well. So I can cope by modifying my activities. Mm-hmm. So it's never really black and white to say what, you know, that we have to do something all the time. It's great to have that shared decision making with your patient, and the more informed you can make your patient, the better.
And there also a question asked about, do you consider there's an optimum time frame for operating on a meniscal tear?
Yeah, pretty much. It's the sooner the better, really. If it's a repairable tear, the sooner you can do it, the more likely it is for the repair to heal.
Mm-hmm. And what length of time would you expect physio to try conservative measures before you want to operate?
Again, it's that shared decision making. So it depends on the individual. It depends on their individual injury, any coexisting injuries, their expectations, and their urgency. Really, if it's an elite level footballer who tears their ACL, we know that the chances of them coming back to professional play aren't really that high with non-operative treatment. So you wouldn't really try them on that because you've got an operation it's not perfect. You know, not everyone comes back after an ACL reconstruction, but you've got a more consistent pathway. And so for those players and individuals, you're more likely to operate sooner.
Okay. And Iona asked for a knee ligament tear, not a rupture. Is it best to limit range of motion and loading for a week, perhaps, maybe in a brace, and let the ligament tighten up over time before loading flexion and extension?
Oh, that's a great question. Kudos, Iona, for asking that question. I really enjoy that question. I'm going to take MCL as an example. So traditionally, we used to splint the leg, full extension, and let it stiffen up and tighten up, and hopefully there'd be a bit of healing. Then came this philosophy of mechanotherapy, the idea that people heal in relation to force, and the idea that early mobilization might be a good thing. And that's where I think actually bracing works really well. So with an MCL, you're effectively protecting the medial lateral deviation with a brace, but you're still allowing some movement. So you're hopefully getting the best of both worlds. Stable enough for some healing traditionally to fit that theory, but allowing motion and allowing that mechanotherapy to help as well.
Okay, great. And Hafiz is asking, what's the recommended treatment option for meniscal injury, and is it safe to play with a meniscal injury?
It really depends what the meniscal injury is. If it's a young person who's got a bucket-handled tear of the meniscus, you'd be keen to try and repair that if at all possible, particularly if it's a lateral meniscus. What we know from studies that have been performed within the Premier League is that if a player has a torn lateral meniscus and has a meniscectomy rather than a repair, their average career length after that operation is something like 3.5 to 4 years or seasons. If it's the medial side, though, we know that's up to 8 or 9. So it makes a huge impact, not just where the tear is, what type of tear it is, what size of tear it is, and what age the patient is as well. Because a younger patient, one, is more likely to heal, and two, has a longer lifespan potentially without a meniscus if we took it out. So for Hafiz's question, I'd say I'd be more inclined to do it sooner in a younger patient if there's a repairable meniscus tear there.
Okay. And Adnan's asking, if someone had a meniscal tear but no locking, but functional limitation due to pain, would you operate on this?
Yeah, and we have done. That's not an unusual scenario. It's often more with patients who have non-repairable tears. So the kind of radial tear, horizontal cleavage tear, they might not have that instability of the meniscus flicking in and out of the joint, which causes the locking, but it causes pain. And the reason it causes pain is because of traction. So particularly with a radial tear, a flap will come in and out of the joint. Not significant enough to lock the knee, but there will be some traction injury on that flap, and that pulls against the residual meniscus. Now, the meniscus, as we know, is aneural and avascular. So it's got no nerves within it, so we can't feel any pain within our meniscus tear. Where we feel the pain is on the capsule with that traction. So in those situations, you get this pain, no locking, and actually debriding the meniscus to a stable rim carries with it good results, and people get a really, most of the time, really good improvement in their pain.
Okay, great. Someone's asked, continuing support with a brace, good idea or a bad idea?
Yeah, so I'm glad you put that you're anonymous who asked that question. I'm surrounded by Össur here. They sell braces for a living, man. What do you expect me to have to say about that? They say it's a good idea, and I think ultimately, you know, if it helps you play your sport, it's about how important sport to you. And if a brace helps you play sport, then yeah, wear it. I wear a brace when I go skiing. It allows me to ski, and I like that. That's good.
Okay, and Kate asks, how common is a cyclops lesion post-ACL?
It's a great question, Kate. It depends on your technique, really. So, you know, you look at some of the studies altogether, they'd rate it 2 to 3% at the most. Touch wood, famous last words here. I've not had one yet, and I think you've got to be quite fastidious about it when you're doing your reconstruction to make sure that you're not going to end up with a cyclops lesion. Could
you explain a little bit about cyclops lesion?
I'll do that. Cyclops lesion is where part of the ACL during the reconstruction, for those of us, let's go back a step. There's a couple of different philosophies to ACL reconstruction. There's ligament preservation and there's non-ligament preservation. Now, traditionally, we'd be happy that the graft is going to be all we need. So we'd go in, we'd debride out the femoral aspect of the ACL, we'd debride out the tibial aspect of the ACL, completely clear the knee of the ACL, and then we'd pass the graft up. With ligament preservation, you try and maintain the native ACL for a couple of reasons. One is that it supposedly helps with post-operative proprioception, and second, helps integrate that graft into the host body. But by keeping more tissue, there's a risk of having a bulk of tissue at the front of the knee, a so-called cyclops-type lesion. Okay. And what that does is that restricts your full extension. Okay. There are ways to avoid it, but if you look at the literature, it is 2 or 3%. Now, it can be resolved if you have one. It needs another arthroscopy, it needs another operation, and often that anterior aspect has to be debrided. But if you're careful about it, you probably could avoid doing it. Yeah.
Okay, and we're down to the last 5, I think. So Mohammed's asking, can chondromalacia patella lead to an individual being ruled out of sports activity?
It's interesting. I think chondromalacia patella, it falls into that basket of anterior knee pain. And it's hard to fathom exactly why do people get pain from softening of the patellar cartilage when lots of people have it and it's not so much of an issue for them. But can it lead to an individual being ruled out of any sports? Well, I guess it could do. But I'd be reluctant to label someone with a chondromalacia patella the first time you see them. Try and have a look for any other potential causes of anterior knee pain. We now know the fat pad can impinge behind the patella, and that could actually give a similar type of phenomenon. And if we debride that, it's a fairly easy thing to clear up and solve for a patient.
Okay, Mohammed's asking, what about failed ACL reconstructions? What do you do with those?
It's a difficult one. You have to sit down and have a good chat with the patient. We know failures happen. The native ACL can get torn. The reconstructed ACL can certainly therefore get torn. It's not as good as the original. And the second time you do it, it's not going to be as good probably as the first time you do it. So a failed ACL reconstruction is a difficult thing. It's nice if you can identify what the cause of the failure was. And probably the easiest thing as a surgeon to identify is if the tunnels are in the wrong position. That gives us a logical answer to why it failed. The hardest ones, though, are when the tunnels are in the absolute right position. The surgery's been done by a well-respected surgeon who knows what they're doing. The patient's done the rehab. The physios are happy. They've gone back to play at the right times, and yet they've still re-ruptured or failed. And that's a really tough pill to swallow as the surgeon. But what we're learning now is that there's more reasons for it. One of our questions earlier touched on the fact that, I think it was Jay who asked, is the posterolateral corner ignored? Well, yeah, it can be. And this is the case that sometimes an ACL reconstruction could fail when everything else looks good, because not all of the damaged issues have been treated. We're now looking more and more about the lateral extra-articular procedures as well to augment the ACL reconstruction. It's beyond the realm of tonight's conversation, but I'd encourage people to go away and have a look at the anterolateral ligament and see what information's come out about that in the last few years. And then also the revisiting of an operation that was done 40 years ago in a Macintosh or a Lemaire procedure as a lateral extra-articular procedure to help with the rotational stability, so not leaving all the rotational stability down to the ACL. So there are other things that can contribute. Okay. Recently in South Africa, sorry to go on, he's asked a great question, I can't stop myself now. Recently in South Africa, Willem van der Merwe has looked into genetics of why an ACL may fail. We all know we've got different ligamentous laxity along the pathway. And a lot of us will be familiar with the Baton score. So if we're doing a hamstrings ACL on an individual, semitendinosus gracilis graft, whip stitch together, lay over an endo button, fix with the interference screw, standard, well-recognized, accepted technique of ACL reconstruction. Someone's got a Baton score of 8, they've got more ligamentous laxity. So my feeling is that perhaps that patient, even if everything else is right, the graft is wrong. The graft could potentially stretch out. So that's another reason, and that's something that certainly in South Africa, they're looking into the genetics of grafts and graft failure perhaps as well.
Okay, thank you very much. And I think we're on to the last question. How long does it take to heal an ACL injury with conservative measures without surgery?
Well, that's a good question. I don't think the ACL injury heals per se. So the ACL tear doesn't necessarily heal. But often people can get on with their lives day to day. And that's often because the ACL can rupture from its proximal origin and maybe stick down onto the PCL as well. With that, it gives you some AP stability. It's the rotational stability you don't maintain. But with that AP stability, you can do a vast majority of sports, particularly inline sports even, at a very high level. It's the rotation that would be a problem. That would probably take about 3 or 4 months before the patient would feel comfortable doing that. But the ACL tear in itself doesn't tend to heal back to what it would do. Now, interestingly, if you look at the science of the ACL and lab studies of the ACL wants to heal. So when the ACL tears, it wants to heal. But it just hasn't got a scaffold on which to heal on. That's why in recent times ACL repair, augmented by an internal brace as well, has gained a bit of potential. Yep. Or indeed, I know your company is looking at making a brace for an ACL. Mm-hmm. It might well be that your brace, when given in the immediate injury, can actually realign the tibia and femur to the right position and allow the ACL, if it's ruptured off the origin of the femur, to actually heal back onto the femur rather than the PCL. Certainly an interesting food for thought as we go forward.
So there are 3 more questions. I think we're going to end it at 3, at these last 3. So don't put any more questions in. But
you can put questions into the question bit, and we can answer them.
We can, absolutely, afterwards.
So yeah, we can get back to you on email that way if you've got questions.
Yeah. So Sam's asking, in what population are you considering a lateral tenodesis along with ACL reconstruction?
Great question, Sam. I don't think any of us really know the exact indications for it just yet. Anecdotally, and I think picking up from listening to a lot of people who know a lot more about this than me, people who have revisions, I tend to do it for. People who have a really dynamic pivot shift. These are the individuals in whom you really can pivot them, and even in the clinic, and they're very, very unstable. I like to do it in people who just open up slightly into varus as well. I think they benefit from it. And recently, I don't know how useful this is, but when I get someone really acutely, knowing now where the ALL, the anterolateral ligament, has been suggested as being, if I run my thumb over that area, if someone's got tenderness over, particularly the mid portion or indeed the insertion where a second fracture would be, that would be an indication as well for it.
Okay. Do tendons themselves actually heal? Adductor, for example?
Yeah, the other comment there is the Achilles. So yeah, tendons heal, mid-substance tears can heal. It's a question of, what to treat and how to treat them. For instance, an Achilles tendon, mid-substance tear will heal. We now know functional bracing gets just as good, if not better, results than an operation, and you'd reserve the operation for an elite level athlete where power and rate of muscle contraction is essential. But for the vast majority of the population, non-operative treatment with functional bracing works well for Achilles, and that can heal insertional or mid-substance. Something like a distal biceps or a supraspinatus tear doesn't tend to heal. And I think part of this is, again, due to mechanotherapy and the idea of functional weight bearing and functional loaded movement, because you can do that in the lower limb. You can't necessarily do it in the upper limb. So those ones would be more likely to repair, particularly for an elite athlete.
Okay, and the final question, do you find injury to any of the posterior structures of the knee commonly cause pain in the popliteal fossa?
Yeah, the commonest cause of pain in the popliteal fossa, I find, is swelling.
Okay.
People who have an effusion often complain of pain in the popliteal fossa. That's the part at the back of the knee. And effectively, what we find is that it's just irritant. And it's not a big effusion either. It's when you've got over the big effusion, you're down to just a small trace of effusion within the knee, and it causes some irritation of the posterior capsule and in the popliteal fossa. And to be honest, that's the biggest cause of pain there, I find. Yeah. In terms of actual posterior structures, though, just touching on the question again, a PCL injury may cause pain there. Posterolateral corner injury will cause pain there as well. So actually, when you're doing the dial test, the patient's prone. It's always worthwhile having a palpation in the posterolateral corner as well. If they're tender there, that's probably a bad sign for posterolateral corner injury, right?
Okay, fantastic. Just remains to say thank you very much. I'm sure everyone in the audience has really appreciated you hanging around for all the questions and the fantastic presentation. So thank you very much.
My pleasure. Thanks again to yourself, Giles. Thanks to Össur. But crucially, thanks to everyone for tuning in and listening. It's been a pleasure.
So there will be more webinars coming to you. We're hoping to have these every month. So do keep an eye on our site. You will see them coming up. So just remains to say thank you very much. Do fill out the questionnaire that will be coming out to you. And we will also send you out an e-certificate as well. Have a good evening.